Welcome back to Clinically Clear, guys. Today we'll be covering a few non-allergic rhinitis. See, these first few ones, I'll be doing them pretty quickly. They're not very important, just maybe for MCQs, etc. So let's get started. First of all, we have honeymoon rhinitis. See, honeymoon rhinitis is when the patient starts feeling nasal congestion following any sexual exposure. Now, I don't know, unfortunately or fortunately, I have not been fortunate enough to experience something like this. So let's move on to the next one. Gustatory rhinitis is when the patient eats some spicy food. Because of the spicy food, the capsaicin, it triggers the cholinergic nerve endings. When it triggers the cholinergic nerve endings, what happens? The nasal secretion increases. And once the nasal secretion increases, it can lead to congestion. So how will you treat it? You will give anticholinergics, ipratropium bromide intranasal spray. That is one more thing. Then you have something known as non-airflow rhinitis. When there is no airflow to the nasal cavity, like tracheostomy, like choanal atresia, adenoids, then because of the lack of airflow, there is inflammation. The turbinate mucosa becomes edematous and leads to rhinitis. That is non-airflow rhinitis. Emotional rhinitis. When the patient has excessive stress, anxiety, then you will give antidepressants, you will give antipsychotics, etc., psychotherapy to prevent rhinitis. Pregnancy rhinitis, because of some hormonal changes, patient is experiencing some nasal congestion, etc. For that, you will try to prefer local measures such as topical nasal decongestants, etc., over systemic drugs, because the teratogenic potential we are still not fully aware of all. Like some antihistamines of first generation and all, they can be very teratogenic. So you have to prefer local remedies. Then some drug induced rhinitis, sympatholytic drugs, those drugs that decrease sympathetic, so indirectly parasympathetic increases, or cholinomimetic drugs, parasympathomimetic drugs like neostigmine, they can increase parasympathetic, and whenever parasympathetic increases, we know that it causes rhinitis. I'll come to how later. In hypothyroidism also similar thing happens. What happens? Because of reduced thyroid hormone, reduced sympathetic discharge, that can lead to increased parasympathetic, imbalance in sympathetic and parasympathetic, basically leading to rhinitis. How will you treat it? Just correct the hypothyroidism. Done. Now let's come to the important topic, vasomotor rhinitis. Now, vasomotor rhinitis is a form of non-allergic rhinitis that mimics allergic rhinitis. It is non-allergic, it is perennial, it is present throughout the year, but it mimics allergic rhinitis. All tests for allergy are negative. You do any skin prick test, anything, it will come out negative. What is the reason? See, in our body, there is parasympathetic discharge to the nose, there is nasal mucosa, there is sympathetic discharge. Parasympathetic discharge always causes vasodilation. And when you cause vasodilation, there is increased mucus secretion. Why? Because of increased fluid. Similarly, sympathetic discharge causes vasoconstriction. And when there is vasoconstriction, there is always decrease mucus secretion. So in vasomotor rhinitis, what happens? There is excessive parasympathetic stimulation and very, very less sympathetic stimulation. So because of that, there is too much nasal mucosal secretion. That's the funda of the whole thing. Why does it happen? See, genetic factors plays a very important role. But there are certain triggers, some physical triggers and some psychological triggers. Psychological triggers could be trauma, sudden emotional stress, sudden emotional disturbances, stress, trauma, etc. That can be a psychological trigger. Physical triggers can be a sudden gust of wind, sudden change in temperature, change in humidity, dust exposure. Those all can be physical triggers. See, if you think about it, that also is mimicking allergic rhinitis. Even in allergic rhinitis, we're exposed to the allergen and we immediately experience symptoms. Here also, some trigger is there and immediately patient starts getting a lot of discharge. So every step of the way, it is mimicking allergic rhinitis. You have to be very, very, very careful. Then the main symptom is nasal discharge. Why? Lot of nasal discharge. Why? Because of increased parasympathetic secretion, right? Thin, watery, profuse serous discharge. Again, just like allergic rhinitis, serous, watery, profuse, thin discharge. But unlike CSF rhinorrhea, on handkerchief it will cause crusting. You might have seen when you have a common cold, and you've used a handkerchief to clean your nose or something, and after a while you've let the handkerchief dry somewhere. The mucus discharge forms a crust over the kerchief. CSF rhinorrhea, there'll be no crusting, but these nasal discharge, there'll always be crusting. So that is one point. Then so much secretion that can even drip posteriorly, post nasal drip. And once again, mimicking allergic rhinitis, sneezing, paroxysmal sneezing. In the morning, patients start sneezing excessively again and again, 18 to 20 episodes, sneezing. That is one more. And because of excessive discharge, what will be there? Edematous mucosa. Because of the hypertrophy turbinates, congested edematous mucosa, excessive nasal discharge, there is always nasal obstruction. More on the dependent side. When you're lying down on the right side, the dependent side will have more of nasal obstruction. Sign. Once again, signs just like allergic rhinitis. You have congested mucosa, edematous mucosa, turbinate hypertrophy. Complications, polyps, sinusitis, not important. Leave it. Then coming to the treatment. Treatment, what you'll do, you will first of all, there is no exact cure, okay? You have to avoid the physical triggers. You have to remove the psychological triggers. You should send the patient to psychotherapy for, you can give antidepressants, you can give antipsychotics, etc. And you can also avoid the physical triggers. And to reduce the symptoms that mimic allergic rhinitis, you can give anti-allergic medicine like steroids, topical steroids, antihistaminics. You can give topical nasal decongestants, etc., which can reduce the symptoms. If it is very severe, you will give anticholinergic, that is intranasal ipratropium bromide. Ipratropium bromide is anticholinergic. It will reduce the cholinergic stimulation, thereby reducing the secretion. But you should not repetitively use ipratropium bromide, only if it is severe. This is medical treatment. So avoid the physical trigger, avoid the psychological trigger, and symptom relief how? Through antihistamine, steroids, decongestants, and if very, very severe, then intranasal ipratropium bromide. Then surgical, how will do? If there is hypertrophy turbinate, I told you the signs are edematous congested mucosa, hypertrophy turbinate. You can surgically resect the turbinate. And in very, very severe cases, you can do something known as Vidian neurectomy. Vidian neurectomy, basically, the parasympathetic, the secretomotor supply to our nasal mucosa is by a nerve known as Vidian nerve. So if we just surgically dissect, or like what do you call, cut this Vidian nerve, then you completely eliminate the secretomotor nerve supply, the parasympathetic nerve supply. So that is the extreme case you'll do Vidian neurectomy. So surgically you can resect the hypertrophy turbinate, you can do Vidian neurectomy. That is it for vasomotor rhinitis. Common 5-mark question. See, here I've kept it a bit short, but each of these you try to elaborate a bit. Just add a few own words. That'll be helpful. Then it is actually a 5-mark question, so you have to write it quite elaborately. Then coming to rhinitis medicamentosa. This is also a very common 3-mark question. Medicamentosa, something to do with medicine. So basically, as you can see here, you have nasal spray. This is what? Topical nasal decongestant. 0.1% oxymetazoline, xylometazoline, etc. So let's say the patient keeps on using this again and again and again. Overuse. This leads to rebound congestion. Instead of causing decongestion, there is rebound congestion. That will lead to rhinitis, inflammation, edema, nasal obstruction, discharge, all the same basic symptoms. Then treatment, withdraw the drug immediately. Immediately stop the topical nasal decongestant and give a short steroid course for its anti-inflammatory effects. Short course of steroids, and any turbinate hypertrophy here also surgically resect it. So what is it? Overuse of topical nasal decongestants lead to rebound congestion, rhinitis medicamentosa. How will you treat it? Stop the drug immediately, give a short dose of steroid, surgically resect any turbinate, any hypertrophy turbinate. That is it for vasomotor rhinitis and other some forms of rhinitis. Thank you for watching.